So we have 22 attendees. So I think we can start, right?
Yes. Okay.
Yeah. So welcome the attendees to Zoom room number 5, and we have our presenter, Dr. Eckhard, who will present PPH emergency care. And this is specifically using the bundle approach. And we will have around 15 minutes for presentation, and then we have a question and answer for around 20 minutes. And so you can type your question while the presentation is going on the Q&A chat. So Dr. Eckhard, please welcome and share what you have to share.
Thank you. And good day, everyone. I'm excited to be able to talk with you about PPH emergency care using a bundle approach, or PPH EMC. And I'm honored that you'd take the time to join this session. Let's see if I can figure out how to move the slides. One moment. There we go. Okay. So we all have agreed, I mean, it's why we're here, that PPH is a problem around the world, and it's a problem that we can do something about. We have good news, which is that we as a global community have learned a lot about this problem over the past 10 years. And just seeing the drones a few minutes ago helps us get excited about innovations that are happening. Dr. Lillestrand yesterday spoke about some of these recent changes and opportunities. We know that no single intervention is going to be a magic bullet to solve this problem, and so we have to have an integrative yet approachable way to help make the changes required to save women's lives from PPH. So we thought, what if we could take the latest in new clinical interventions, the latest in medical education methodologies, the latest in behavioral sciences, and the latest in health system strengthening, and put it together? What would that look like? And that vision became PPH EMC. So PPH EMC creates a new way of responding to PPH emergencies, and by extension, all obstetric emergencies, through creation and implementation of an obstetric rapid response team, use of bundled clinical elements, and then a focus on sustainable team-based approaches to both clinical and health system solutions to obstetric emergency. The focus is around facility-based pre-surgical interventions to treat PPH. And there's two main interactive components to this program. There's the clinical, which includes the PPH emergency response. That's the latest clinical interventions, UBT, NASG, tranexamic acid, placed in a comprehensive training around postpartum hemorrhage. And there's the bundle approach, of course, included with that. And then there's non-clinical modules. And these are elements that provide the foundation for any successful clinical endeavor, but we don't talk about them enough. And they're often the things that have gaps in them when we're trying to administer good quality PPH care. These areas are teamwork and communication, network integration, facility readiness, leadership, and data monitoring and quality improvement. And so the training on the non-clinical elements involves workshops, activities, and toolkits. And each of the toolkits can be used as a facility-based quality improvement project. It contains planning, implementation, and monitoring or measuring sections. So our team has been working in PPH research, implementation, and training for over 15 years. We've developed several training programs before, so why do another one? And I think it really speaks to the uniqueness of the bundle approach and the integration of health systems training and solutions, and how important that really is. So a lot of important work went into the PPH EMC platform, but I want to just mention 3 bodies of work to highlight how they really informed the development of the PPH EMC intervention. They're the ones that are listed here. The WHO technical consultation on PPH bundles was supported by the Bill and Melinda Gates Foundation and led by WHO. This technical consultation group worked on identifying specific point of care interventions for PPH that could be packaged into clinical bundles. And over 2 years, they reviewed literature, talked to experts, met together, and all of this work culminated in a meeting in Boston in December 2017. And the work was published in IJGO in November of 2019. And they identified the first response bundle and the refractory PPH interventions. And these became the starting point for a Bill and Melinda Gates Foundation planning grant to create the PPH emergency care using a bundle approach. Items identified in the WHO PPH technical consultation are here on this card on the left-hand side. They are lines 1 and 3, the areas surrounded by magenta rectangle. We also include on this supportive measures because we want to make sure we have the right diagnosis for PPH, etc. But this is the training card that is used for the clinical components within PPH emergency care training. So what's a clinical bundle? Well, it has 3 parts. It has a trigger. A trigger is the clinical condition or diagnosis that informs the team to use the bundle. In this case, for the first response bundle, it's a diagnosis of postpartum hemorrhage. That's the trigger. And then you put into action a set of actions. So rather than making a decision about each particular component, waiting to see if it works and then going on to the next one, as soon as you have the trigger, you do all the things in the bundle together. And then there's compliance measures. And compliance is measured by, did we do all the things in the bundle every time the trigger was seen? That's how a clinical bundle works. And in addition, though, to the clinical training, we also need to think about the non-clinical pieces of developing a good PPH quality care system. So behavioral research helps to highlight why new clinical interventions and training alone are not enough to achieve quality PPH care. So this work was done by Harvard School of Public Health in partnership with the Kenyon Medical Education Trust and the Global Health Innovation Lab at Massachusetts General Hospital. The main outcome that we learned is that people don't always do what they know to do because there are other factors at work that affect behavior. So this study was implemented in Nairobi in Western Kenya in 3 large maternity hospitals. It was a mixed methods study design, so there were qualitative interviews, there were delivery observations, there were facility assessments, health worker knowledge assessments. Quite a large body of work with over 900 deliveries observed, and for some of those deliveries, more than 1,000 data points were collected, so a lot of data. They use these to examine the potential drivers of quality. That includes supply availability, knowledge, staffing, provider behavior, provider decision-making. Excuse me. And here are some of the key findings. So knowledge in many areas was really quite good. The providers knew what the recommendations were for quality care. But even when knowledge was high, supplies were good, and the facility was not so busy, the coverage of many of the quality measures was still only around 60%. So providers know what to do, but they're not always doing it. And we realized what we need to do is create an environment that promotes the right work that we know to do. There are other things that drive our behavior. And so we thought, can we arrange the expectations, the norms, the environment, the team, so that what providers know to do becomes a reality? And this is what the non-clinical elements seek to help facility and care teams do. So we incorporated those lessons from the behavioral sciences research There's an emphasis on facility and systems level change to enable provider behavior. And the participants explore these changes within the 5 non-clinical areas. And we have several tools that we use within that. We have here 2 types of tools shown. The one on the left is postpartum monitoring. You may have noticed that was one of the big gaps in the behavioral sciences research. And we've just shown you a couple of pages from the inside of that toolkit. What the toolkit allows a group to do is a facility, leaders can sit together, go through the toolkit. They will think about what's working well in our facility, what maybe needs to be improved in our facility. There are ideas for how to implement changes to make those improvements, but certainly the group can pick another way to implement improvements. And then there's a section on how to monitor whether your improvements are doing what you hope that they'll do and making the changes you want. There are also resource guides, and this resource guide that's shown here is to help set up a simulation program. So facilities can start to put together an organized way of continuing to help practice what happens in emergency so that they're ready before the emergency comes. And this doesn't require an expensive simulation lab. It's a way to improve teamwork together through this simulation program. Excuse me. And then the third body of work is co-creation and initial implementation with international partners. We have amazing partners in India and in Kenya. In India, the Mahatma Gandhi Institute for Medical Sciences led this initiative with 10 other medical colleges. We had the privilege of working with the highest level of professors from those colleges. Very innovative group who really focused on thinking about how to make the clinical intervention happen, as well as how to think about these non-clinical elements in creative ways. They came up with the ideas, they tried things out. We would go back and write a section of the training and bring it back to them. They would adjust that section, maybe try new ideas. And so we did this several times over the course of a few years, and really learned a lot from that. And then we were able to take the whole program to Kenya with the Kenya Medical Education Trust, and they rolled out the entire program in a completely new setting for us to see how would this work in a new environment, in a new setting. And I won't go through every lesson that was learned. We don't have time for all of them, but I will say that the bundle concept really is very well received. And it's also really important but helpful to have a lot of flexibility within the programs and to have it really be led by the county or by the facilities so that leaders can pick, these are the areas that we're weak on. This is how we can work to improve PPH emergency care. And it helps expand thinking beyond it's just a group of clinical interventions to we really have to have a system, an environment to help support the good care taking place. It's also, a place to start. So we do a PPH EMC training, but there needs to be continued assistance and mentorship because it's just the starting line. We're not just trying to deliver, new changes, new interventions and be done. We are trying to create a culture of continued improvement so that facilities not only learn how to improve things, but they learn how to continually evaluate, create new innovations, and take the quality care to the next level. So think about the last PPH you were involved with. For many of our colleagues, the health system creates delays that hamper our success. So we know what it looks like when there are difficulties. Let's think about what might happen if things worked perfectly and if we could really implement some of the things that PPH EMC helps facilities think about doing. So Maria goes into labor. She's taken to the nearest health center. Labor goes fairly well and she delivers a bouncing baby boy. Everyone celebrates. She's taken to the postpartum ward. Because she's monitored well, a nurse notices when she has a delayed postpartum hemorrhage. The nurse immediately sounds the alarm to get help. and the obstetric rapid response team immediately arrives. They can do this because the unit has been organized so they can be freed up as soon as they're needed for an emergency. Supplies are immediately available because they're stocked and checked regularly. Each person knows exactly what they need to do based on their role because they've regularly practiced with simulations. The communication is done using closed loop communication techniques. Everything is efficient and orderly. So they begin the first response bundle immediately. An IV already has been placed by the first nurse. They massage, they give IV fluids, oxytocin, tranexamic acid. On examination, they confirm the bleeding is due to uterine atony. And they continue with these first response bundle measures. In this case, they even add misoprostol, but the bleeding does not stop. So they initiate the refractory PPH interventions, initially applying bimanual compression while the UBT is made ready. It's placed, the bleeding stops, but now Maria is showing signs of shock, so the NASG is placed. Now, while the refractory PPH interventions are being done, a team member calls the ambulance. And the team member also sends a WhatsApp text to the referral hospital giving information on the patient using SBAR, a communication tool for handoff. Further questions and information is exchanged as needed, and the team at the referral hospital is fully informed and ready. The providers who are communicating are familiar with each other, and they feel they're on the same team. Once the ambulance is on its way, the ORRT gets together and has a debrief. What went well? How can they do better? So that next time they're even more efficient and prepared. They identify some things that could be improved and bring them to the quality improvement team. Meanwhile, the ambulance arrives at the referral hospital. The ORRT, or the Obstetric Rapid Response Team, is notified of Maria's arrival and is immediately able to step into action because they've had a team huddle about the patient before she arrives. Thankfully, she remains stable with the UBT and NASG in place. She needs a blood transfusion and careful monitoring, which she receives. During her stay, the referral hospital and health center stay in contact to answer questions and to provide updates. And then a couple days later, Maria is able to be discharged from the hospital. She and her baby are well. Some of these things may seem like a dream in some settings, but each of these areas are really carefully addressed in the PPH EMC. And we've already seen a great deal of progress toward this kind of quality care in places where we've rolled out PPH EMC. So next, we are currently working with FIGO and IDB, along with national OBGYN societies, government, and implementing partners toward implementation in these countries. We've really enjoyed working with the partners that have contributed to PPH EMC. I want to particularly mention the Bill and Melinda Gates Foundation, FIGO, KMET, and MGIMS, the Mahatma Gandhi Institute. And I'd be happy to take your questions. Are there any questions?
Okay, thank you, Dr. Eckhard, for such a nice presentation on such a wonderful innovation on PPH emergency care using bundle approach. And so we have some question, and one is talking about if there is any data on whether the tools worked to change the behavior. So if there's any metrics that have been used to see a behavior change, and so the other question is talking about is there a list of minimum standards that the health facility should meet before you would recommend this this bundle? For example, yeah. And then we have another question on. So I understand the recognition of PPH is a challenge. So what lesson did you learn about recognition, the identification of the PPH, and then triggering the bundle beyond the need for postpartum monitoring?
Okay,
So
great.
welcome.
Thank you. So let me start in backwards order, and then if I forget the first question, you can help me remember. So identification of PPH is really a challenge, right? Because we have a definition, which is more than 500 cc's for a vaginal birth, but we also know that some people get sicker sooner than that. Some people bleed really fast. Some people just trickle, and they trickle for a long time, and you don't really realize how much blood they're losing. Most of our monitoring techniques, if we actually tried to monitor, they're a drape that you put under the patient during delivery, but that drape doesn't stay there for very long. So there are definitely challenges around identification, and we probably under-identify all the time. So what we first have started to do in the training program is talk about this problem, that it's hard to identify, and that you have to be really vigilant, and you have to act quickly. So we encourage early activity. Now, certainly if there is, some methods that are already used in the facility for measuring PPH, we support those. But we really focus on early identification and not waiting until you think that you've measured just enough blood loss to call a PPH, because sometimes it's really about the rate. Bleeding is really fast. I know that's not particularly specific, but that's because we don't get particularly specific. We try to have the conversation and talk about ways in which we can help people identify sooner. Another one of the questions, help me, Joseph, what's another one of the questions? Are you there?
Dr. Eckert, if you click on Q&A at the bottom of your screen, if you're able to, then you can also.
Yeah, so I'll stop share and then I can
Okay.
do that. Yeah, I just had that up because people could see what the components were.
Yeah.
Yeah. Okay, so data on whether the tools work to change behavior. So the data around improvement is really based on observation. So we don't have, it's new, it was rolled out just several months ago. So we don't have quantitative data, but we have qualitative data. What we've done is tracked the different sections of PPH emergency care at the county level, and they've looked at the different sections of PPH emergency care and when they were planned, implemented, mastered at the different facilities. And so you can see over time the observed change in behavior by seeing how they have improved each of the sections of PPH EMC depending on what they're working on. What's different about this program is that we don't define these are the orders in which you need to uptake the changes. We work with the facility by giving them inspiration, new ways of thinking, some toolkits to use to try to make the improvements, and then helping them get together and have the conversations about where do we need to start for our facility. So as we go into these next countries and into this next phase, this was the end of the planning grant, we'll begin to be able to gather some more reportable, robust data to be able to help with that.
Yeah, the other one was about if there's any minimum standard that the facility should meet before you introduce the
Yes, right. So, we have been using minimum standards. One of the, and I don't have them all in front of me, so I'm coming off the top of my head. One of them is that we really do have to have a way to do quality improvement. So the facilities we start with the medical centers, the largest centers, which is a new way for us to do things. In the past, we've started at the PHC level because a lot of the needs are at the PHC level. But we've learned that you need to start at the top with the people that are well respected and have fairly functioning systems, so they can then begin to train and get on board their PHCs that are referring to them. So it works more in a hub and spoke fashion. And the minimum standards, again, this is there's a list of interventions. So the clinical interventions, yes, the minimum standard is we want people to use the clinical bundles 95% of the time that the trigger is there. So when you get a PPH diagnosis, 95% of the time, the bundle should be used. So there is a minimum standard there. It takes time to get there. So we have, but you see improvement, but we haven't reached 95%. That's the goal. Then on the other pieces, what we want people to do is over time to work on them and to pick priorities. So I mentioned before, there's the list that we have used with county coordinators. Each month, the team sits down, looks at, okay, have we worked on postpartum monitoring yet? Have we talked about some of these issues around leadership? Have we really put together our obstetric rapid response teams? Do we have our simulations in order? And we have a little bit of guidelines around how that should start. We recommend they start with their obstetric rapid response team very early, that they work on debrief tools, and every emergency is followed by a debrief tool very early. So there are some starred areas, but then there are also a lot of flexibility within facilities based on their priorities and needs. So I hope that answers. Yeah.
Yeah. So there's another question that we have other maternal complication like sepsis, eclampsia. So the question is if such kind of complication can also be integrated using bundle approach model.
For me, you cut out just a little bit. Can you repeat that, Joseph? I'm sorry.
I say with other major life-threatening maternal complication, so example sepsis, eclampsia, how can they be integrated into this model?
Thank you. Excellent. That was the piece I missed, sepsis and PPH emergencies. So, eclampsia. So when it comes to other emergencies, the main framework around the non-clinical interventions remains the same. And it very naturally has, in many of our centers, just become part of the use of the communication tools, the network integration, all of that. So the piece that is needed is the clinical response. So are there parts of of preeclampsia? Are there parts of eclampsia? Are there parts of sepsis that we want to bundle? Now, sepsis has its own bundle, clinical bundles already that have actually been well researched. And those pieces, sepsis 6, can certainly be integrated into care for pregnant ladies. For preeclampsia and eclampsia, we haven't talked about bundles, and so that would be something that a facility might want to research and look into how to do that, do the bundling. But you still have the obstetric rapid response team. You still have the ability to practice your intervention for eclampsia and use that quickly. And you still have all of the same communication tools, all of the same data and monitoring approaches, all of the same pieces around facility readiness that can be very quickly adjusted. So when we look at the WhatsApp communications that happen in India right now, one patient will have PPH, one patient will have COVID, another patient will have kidney failure. And the communications between the institutions around the referral patients are sometimes asking questions about what can we do with this patient, and getting suggestions from the tertiary care center. Sometimes they're, we're sending a patient and this is what it's about. And it's probably maybe 10% PPH by now, and a lot more some of these other things that are being integrated into the way that the non-clinical components are working.
Okay, thank you. There's I think one last question, which says that it's my understanding that the refractory PPH bundle has not yet been recommended by WHO and needs research to determine its effectiveness. So your posters seem to indicate that this is already an accepted recommendation. How are you ensuring that others know that research is needed in this area?
Thank you for that question. Yeah, so this was the recommendations made by the WHO technical working group, but that group is still working on research around these things. So that is absolutely true. And, you know, in the longer training, we certainly do talk about that. The thing about this PPH emergency response card is that everything on the card is what was in the WHO 2012 recommendations, items that were suggested as being available or items that were recommended. So it's not new. The bundle approach, I suppose, is new because you're doing things faster. It's more of a behavioral intervention than it is a clinical intervention. And I think there is another talk actually right now at this time. Some of you may have gone to the talk that does talk about the clinical trial that's actually in place looking at this first response bundle. So the bundling part of clinical care has been done in other fields. It hasn't been done really officially or tested in the PPH field. And so the use of it now is really extrapolation from those things, but I think it will be very interesting and helpful to know what we learned from the current trial that's being done around first response bundle versus sort of the sequential use of those same interventions. You know, there's certainly questions sometimes around cost and those sorts of things that do come into play. Very good question.
So
thank you.
Thank you. I think in the Q&A, there's no any more questions. So maybe one for me that we know the behavior change needs some measures.
Joseph, I'm so sorry to interrupt. It's Leah, and I'm the designated as timekeeper, the hard stop timekeeper. So we're going to need to send our participants back to the plenary.
Okay, great.
My apologies.
So thank you, Dr. Eckert, for such a wonderful presentation and the response. So let's go back.
Many thanks.
Thank you so much.
Thank you. Thank you, Joseph. Thank you.
So in the chat box, there's a link to go to the website where you can select the Zoom link to get back into the main plenary session if you would like. And thanks again.
Thank you.